Hi there, it's Dr. Ryan, and today we're going to talk about something that is that seems to be a topic that seems to come up pretty frequently in my clinic, and that is what is sex hormone binding globulin, and um, what can we do to increase or lower it as need be. So I've prepared a short presentation on it, and let's go ahead and take a look. So here. Okay, so sex hormone binding globulin, what it is, and how to interpret your results. So what is sex hormone binding globulin, or SHBG? So SHBG is a glycoprotein that binds to androgens and estrogens and essentially modulates them in the body. And so most of your testosterone and estrogen is bound to proteins. A very small amount is free in the blood, and that small portion seems to enact all of the changes that we're aware of, and binds either estrogen or testosterone receptors. And what's important about sex hormone binding globulin is, unlike serum albumin, which also binds testosterone and estrogen, it seems to tightly bind both testosterone and estrogen. So in other words, it limits the availabilities of these hormones significantly. And you can see the binding affinity is actually stronger for testosterone than it is for estrogen or estradiol. And it's approximately 4 times as much as it is for estradiol. So where is it produced? It's produced primarily in the liver, but also produced in the brain, uterus, testes, and placenta. And again, it's useful in the modulation of sex hormones, and this comes into play during human development. So during fetal development, there are low levels of sex hormone binding globulin, which allows higher activity and sex differentiation to a male or female fetus. After birth, it does tend to rise. So there's not a lot of activity during childhood up until puberty, which there is the sex hormones tend to increase, of course, and sex hormone binding globulin decreases to about half its levels in girls and a quarter of its prior levels in boys, and allowing them to develop into men and women. And then in pregnancy, it increases 5 to 10 times. And it's thought that this is secondary to the fact that, again, there are low levels of sex hormone binding globulin in the fetus, right? And because of the higher levels of sex hormones. And this is due to a protective effect, so that the mother may not be affected by those higher levels of hormones circulating, which of course are causing sexual differentiation in the fetus, the developing fetus. So in other words, they limit exposure to androgens and estrogens, and of interest in women, sex hormone binding globulin is generally twice as high as it is versus men. Now, low sex hormone binding globulin levels in terms of clinical correlates have been shown associated with hyperandrogenism as well as endometrial cancer in women, owing to the fact that you have the higher levels of testosterone and estrogen circulating in the bloodstream, and in men may contribute to benign prostatic hyperplasia. High serum hormone binding globulin has been associated with increased vertebral fracture risk among elder men and women, and that's likely due to the decreased amounts of estrogen as well as testosterone, which of course is associated with calcium deposition and better and decreased fracture risk in skeletal bone. In terms of the clinical applications, if you have elevated serum hormone binding globulin, it's going to, or sex hormone binding globulin, it's going to bind DHT and testosterone, which of course will cause symptoms of low testosterone, weight gain, depression, low sex drive, erectile dysfunction. If they're low, of course, you're going to have more unbound or free testosterone, which may cause symptoms, of course, of high testosterone, acne, gynecomastia, or early onset male pattern baldness. Again, the optimal range is 60 to 80 nanomoles per liter. So what are some of the causes of elevated serum hormone binding globulin? Now, most of these seem to be associated with higher estrogen and thyroid levels. So again, elevated estradiol levels, and I see this commonly in individuals that have higher aromatase enzyme at baseline or tend to have a bit more adipose tissue, which there's a lot of aromatase enzyme and therefore higher conversion of testosterone to estrogen. Hyperthyroidism, cirrhosis, which is the elevated thyroid hormone levels, cirrhosis of the liver, where you tend to have more aromatase, thus more estrogen levels and intrabaseline, extreme weight loss, smoking, and high levels of stress. And of course, as I mentioned, estrogen conversion from inappropriately dosed TRT. There are certain medications that raise SHBG too. And some of the more common ones include the antipsychotics, the antidepressants, anticonvulsants, drugs used for GERD, such as the H2 receptor antagonists, there's cimetidine, ranitidine, Serums, these are pretty commonly used in breast cancer, spironolactone, and oral contraceptives. And how do we treat elevated serum hormone binding globulin levels? So we want to primarily find out what the underlying cause is. That's the key thing. First and foremost, is it medications? Is it inappropriate TRT administration? Is it high thyroid levels? Is it liver dysfunction? So try to optimize those at its core. So optimizing estrogen levels, optimizing thyroid levels, avoiding smoking, decreasing cortisol levels through stress management and adaptogens such as ashwagandha or rhodiola, correcting an overrestriction of carbs and calories, having a more healthier diet, and then utilizing omega-3 fatty acids seem to help too. And what about some of the causes of low SHBG? Well, again, it's generally due to low estrogen and thyroid levels and higher insulin levels. So we tend to see it in obesity, hypothyroidism, metabolic syndrome, which is associated with insulin resistance, and overuse of aromatase inhibitors, where estrogen levels tend to be a little bit lower. So again, when we want to treat this, we want to elucidate the cause first and then go ahead and move on, rather than just taking things to try to drop the serum hormone, or the sex hormone binding globulin levels. So doing a proper thyroid evaluation to evaluate if you are hypothyroid, we'll typically look at TSH, free T3 and 4, as well as antibodies against thyroid peroxidase, TSH, etc. Weight loss, so really trying to decrease the amounts of adipose tissue seems to help, because that is important in terms of insulin regulation. Adjustment of your TRT regimen, flax seeds, green tea, catechins, which seem to also decrease SHBG levels, and then dietary changes to improve insulin regulation. And just in terms of those dietary changes, those would be primarily things like making protein the center, things that utilizing macronutrients that don't seem to spike insulin levels. So trying to utilize lean protein that is low in saturated fats, complex carbohydrates, rather than simple sugars, and utilizing monounsaturated versus saturated fats for fat sources. And trying to eat carbohydrates earlier in the day where your metabolism is higher and around your workout, where typically you're able to push your carbohydrates into muscle glycogen, liver glycogen, versus just having it circulate and elevate your insulin levels significantly. Now, your testosterone, in terms of testosterone replacement therapy, one thing that I'm a big fan of in my clinic is microdosing. So using smaller doses versus larger weekly doses. So taking, for example, if you were to be on a weekly dose of 120 milligrams, rather than doing a large shot of that dose, splitting it up into 3 doses of 40 milligrams really seems to optimize estrogen levels. And so again, if you have a large bolus dose of testosterone, you tend to get a spike in estrogen. As we know, increased estradiol levels seem to increase your SHBG, right? And so using smaller doses concurrently can help with that. And then I don't typically check SHBG up front, but I always check free and total testosterone levels. Remember, It's because you have a good total testosterone level. That is a combination of all the testosterone in your blood. So remember, the small portion that's free, the portion that's bound to albumin, and the portion that is bound to SHBG. So really, we ought to look at your free levels, right? And so your free levels are what's going to be important. So I have noticed for the vast majority of my patients, just by modulating their TRT dose, their free levels seem to be appropriate and somewhere between 15 to 20 nanograms per deciliter, or certain labs use picograms per milliliter. That would be like 150 to 200 picograms per milliliter seems to be optimal for most patients. And then, of course, appropriate utilization of aromatase inhibitors. So in those individuals where even if you do use smaller doses, some patients still have higher estrogen levels, utilizing judicious amounts of aromatase inhibitors. I don't typically go above 0.5 milligrams to 1 milligram a week, seem to help. And then, of course, checking to make sure the estradiol levels stay within an appropriate range. Okay, well, that's about it. And hopefully that's been helpful to elucidate my thoughts on SHBG and some of the ways I use, or some of the methods I use to optimize it.